All right. So, isn't technology grand? Hi. I'm Dave Evans. It's great to be here with everybody. We've got coast to coast grand rounds today with people on the West Coast and the East Coast. So, should be lots of fun. So, good afternoon or good morning, depending on where you are. Thanks, Randy, and your team for getting this all together. It's been nice and easy for me and Kim, and we appreciate that. I just wanted to, Randy introduced us with our current UW jobs, but prior to joining the faculty 6 years ago here at UW, I had practiced for 15 years in Central Oregon. And in a small town of about 5,000 people, where we did a fair amount of alcohol-related work, specifically detox and treatment of withdrawal symptoms. So it's fun to talk to you about all this today. I'll let Kim go from here.
Yes, and thank you everybody for being here. Thank you for the kind introduction. And prior to my position at the University of Washington, and I just started a few months ago, I worked in Indian health with the bulk of my clinical time at the Tulalip Tribal Clinic, which is about an hour to an hour and a half outside of Seattle, depending on traffic. And even though there is a suburban area about 25 minutes away from the Tulalip Reservation, getting people to leave the reservation for medical needs often had a number of challenges. So it was a very rural feeling clinic. So that's where I come from before my position at the University of Washington. So we're gonna go ahead and begin.
So I guess, is alcohol-related disease a rural issue? And in some ways, no. It's a pretty common issue everywhere. The prevalence across the U.S. is 9 to 16%, and it's estimated in some circles that up to 9% of visits in a family medicine clinic are related to alcohol dependence, and that's across the board. But lifetime prevalence of alcohol use disorder in rural areas is approaching 33%. So it's really while it's common everywhere, it's particularly common in rural areas. And there are a few unique aspects to alcohol-related disease in rural areas, including more binge drinking, particularly in teens and adults. Folks are more likely to be employed with an alcohol use disorder in a rural setting compared to urban. And of course, the treatment options are significantly different. Resources are always an issue in rural areas. And as primary care physicians, in a rural area, we're much more likely to be dealing with this directly.
So to further discuss alcohol use disorder and detox, we're going to talk about a case. And so let's say you're in your clinic and you have a no-show, and the person triaging slides a walk-in into your schedule with a 43-year-old gentleman who says, "I need my blood pressure checked." You get him back in the room and he tells you, "Actually, doctor, I'm drinking a good amount and my girlfriend kicked me out of the house, won't let me back in until I quit drinking, and so I need your help. I want to see my 3 kids and spend time with my family." On further questioning, you find out he has been drinking intermittently for several years, but the amount increased significantly when his cousin died about 4 years ago. He rarely uses meth. He's been straight up with you. And mostly he says it's so he can stay up to go to work because he's the provider for his family. And P.S. doctor, can we make this quick? Because I got to go to work. and he works as a fisherman. And so sometimes he's out on the boat by himself, and sometimes he does have a co-fisherman with him. So already we can look at some unique rural aspects based on this case. People with alcohol use disorder in rural settings are more likely to be employed. So they're trying to juggle a job. They're more likely to have the criminal justice system involved. Transportation is often an issue. People are traveling more miles to get to your clinic. They may have run into some issues with alcohol and transportation, so they may not have a license and are depending on other people to drive them places. And compared to the urban counterparts, public transportation just usually isn't quite as readily available. There can also be a delay in detox or treatment due to limited facilities in rural areas. So what do? You ask him some more questions and you find out that Daniel, who goes by Junior, his significant other works at the clinic. His mom is a prominent elder in the community, so everybody knows his mom. Lots of people know Junior. You find out his last drink was this morning. He's supposed to be on Lysin April 20, but he's not taking it on a routine basis. He's never had a seizure nor hallucinations because of alcohol. And when he's tried to stop quitting alcohol before, and he finds that he feels very jittery, anxious, and has some trouble sleeping.
So, so he's in your clinic, and you have to figure out what to do. And what you're really worried about here is his potential for withdrawal. If he stops cold turkey, we already know that he gets a little bit jittery. But what else could happen? So this slide really is a graphic of an alcohol withdrawal course, and I'm not going to go over every step of the way with you, but you can see that different symptoms appear at different times. So it's super important to know when your patient had his or her last drink, so you can sort of anticipate when symptoms might occur. So the mild to minor symptoms occur fairly quickly, with 6 hours after last drink, whereas hallucinations and delirium tremens and those sorts of things are going to occur usually 48 or 24 to 48 hours out, sometimes even 72 hours out. So understanding the time course is super important.
Another important aspect is considering where can someone do detox. He's asking for help. And so considering, can a person be treated as an outpatient, or do they need a higher acuity care as an inpatient? So let's go ahead and talk about some of the criteria for outpatient treatment. And those include minor or moderate symptoms. And many people have heard of the CWA instrument, the Clinical Institute Withdrawal Assessment for Alcohol, and there's a revised version. And that can be a tool that can help you. And we'll go into more of that in a couple slides. Other criteria include normal labs, having a support network, so having transportation, having family or friends that are going to help you support you in your sobriety, having a place to live, not having a history of DTs or a history of withdrawal seizure. If people have other medical conditions, making sure that they are overall controlled. So there might be a difference in your mind when you're if someone has diabetes, if their general A1C is 6.5 versus if it often runs 14. There needs to be an absence of serious psychiatric conditions like psychosis or suicidal ideation. Polysubstance abuse often is an indication for inpatient treatment. Not a super long history of large amount of alcohol, and that's going to vary from clinician to clinician. That's really where sort of the art of medicine might come in. And then not being pregnant. So to keep those outpatient treatment criteria in mind. So if you decide to treat someone as an outpatient, what are some regimens that can be considered? Thiamine and folic acid and other vitamin supplements should be given to everybody. Thiamine in particular to prevent Wernicke's encephalopathy. And often when people are struggling with chronic alcohol use, they may have some chronic malnutrition or some even malabsorption issues because of the chronic alcohol use. So everybody should get some vitamins. And then there can be various regimens that work well. Many people are familiar or go to a benzodiazepine regimen, and Librium has been around a long time. And here are some examples of some regimen or two. 50 to 100 milligrams every 6 hours for 4 doses, and then a lower dose at 25 to 50 milligrams every 6 hours for 8 doses, or a more tapering regimen, as you can see here. Valium would be another very reasonable option. Some people are more familiar with Ativan, which is a shorter acting benzodiazepine, and that can often be considered in people who might have more liver damage, or you suspect more liver damage, just because with a longer benzo, the metabolites can build up and be an issue for people with livers that are not working optimally. Other people worry about, hey, someone's struggling with an alcohol use disorder, a substance use disorder, and I'm going to give them something that's highly addictive. So some people have moved to using things like gabapentin or Tegretol, which are also very reasonable. Although benzodiazepines have been shown to be superior in preventing DTs and seizures. Although if you are doing an outpatient regimen, you've considered that, and hopefully someone is not in danger of going to that kind of level of alcohol withdrawal. And then you want to consider following up daily. Some people aren't going to be able to make it to your clinic every day because of their job or because of transportation, but making sure they touch base with you over the phone, perhaps every other day, and coming to the clinic would be reasonable.
So let's get back to our case here for a second. So despite maybe not being the most ideal candidate for outpatient treatment, he really does want to go back to work, and there are some complicating social issues that Kim talked about earlier. So you decide that you are going to treat him as an outpatient with a fixed dose of diazepam. And when you tried to follow up with him, he didn't pick up the phone. He was out at work, did not come in for scheduled follow-up. You returned to the clinic a few days later saying, you know, I took a couple of those pills you gave me, but, you know, I felt funny, so I stopped. And he's returned to drinking again. So when do we consider inpatient treatment? Well, in general in medicine, you consider inpatient treatment for things when they've failed outpatient treatment. And that is what has just happened here with Junior. So he's failed outpatient treatment. He still wants sobriety, and you decide to bring him into the hospital. Other reasons that you would bring a person into the hospital for withdrawal treatment or sobriety treatment would be pregnancy, a known history of DTs or seizures, multiple comorbidities, as Kim talked about earlier, abnormal labs and polysubstance abuse. He does have a meth history, but intermittent, so maybe we should have done this earlier, not sure. And then that CWA score that we talked about. So just wanted to spend a little bit of time on CWA. I don't know how familiar you all are with that, but this is a pretty standard scale that you will see in both the inpatient and outpatient setting. It's the Clinical Institute Withdrawal Assessment, and it looks at a variety of factors in assessing both the presence or absence of withdrawal, as well as the seriousness of withdrawal. So it looks at nausea and vomiting, tremors, vital signs. Is the patient anxious or agitated? Are there any sensory disturbances like auditory or visual hallucinations and things along those lines? And each one of the segments is scaled or is scored on a 1 to 7 scale, and the higher the score, the more concerned you would get. So you'll certainly see CWA scores, or I hope you see CWA scores as you think about this. So, all right. So we talked a little bit about alcohol being a fairly common disease, or alcohol issues being common in all aspects of medicine, but the highlighted rural differences really are lack of specified detox services in most communities, lack of mental health providers and treatment facilities. So these things are going to fall more on you as a rural provider than maybe they might in a city. So physicians need to be more hands-on. They need to be more involved in coordination. They need to be more involved in follow-up. Some knowledge of different drugs is important. We talked about the withdrawal drugs earlier. Vivitrol and naltrexone and these other medicines really are sobriety aids and aftercare issues more than they are withdrawal drugs, but nice to know about those. And then the transportation issues and the privacy issues that we talked about with juniors. So all differences in practicing rural compared to urban.
So in summary, alcohol use disorder and alcohol withdrawal are common medical conditions, and you'll see them in rural settings. Many people qualify for outpatient treatment, and primary care providers are required to know those criteria and know some treatment options for outpatient and when to go to an inpatient option. Resources in the area may be limited, and providers should acknowledge and address specific barriers, like we've said, transportation, wait times to get to specific resources, privacy issues, and employment.